Our next presenter is Dr. Aya Elfiky. Aya, can you hear me? You can start sharing your screen.
Yes, I hear
Dr.
you.
Shaima, please mute yourself.
Can you hear
Dr.
me?
Aya, can you hear me?
Yes, I hear you well. Can you hear me, doctor?
Okay, can you raise your voice a little bit more?
Okay. This well?
Okay, I can see your screen now. Start the slideshow and go on.
Okay. Thank you, Dr. Muhammad, for this opportunity. Today's presentation is with the dress of Big Leaper for diagnosis under supervision of my dear Prof. Dr. Shaima El pathology consultant at Ain Shams University of Medicine. This presentation is about a female patient, 39 years old, presented by periodic vague abdominal pain and constipation for many years. Colonoscopic biopsy performed and sent for pathological examination and diagnosed as mild active proctocolitis with ulceration. But 1 month later, she was presented with gradually worsened abdominal pain, distension, bleeding per rectum. MRI examination revealed pelvic mass versus rectal mass. But BR examination confirmed there was a rectal mass. Colonoscopy revealed rectal mass about 7 cm from inner verge, extending about 4 up to 5 cm, causing partial narrowing of the lumen covered by ulcerated congestive mucosa with area of necrosis, which is a picture of highly suggestive malignancy. So another colonoscopic biopsy was taken. الصورة اللي أنا شايفاها دي this is the colonoscopy. There is a mass with focal area of necrosis, and grossly it was multiple irregular grayish white tissue pieces collectively measured about 0.5 and 0.5 centimeter. Now it's time for H&E. We saw a normal colonoscopic mucosa with focal area of ulceration. This is a hyper on the focal area of ulceration with the infiltration of inflammatory cells. Another area of ulceration underlying oval cells. Another area on 200 high power field with inflammation and granulation. In this area, we saw the underlying inflammatory cells and regenerating crypts. In this area, we can saw hemosiderin-laden macrophage with inflammatory infiltrate. Here is a colonic gland with proliferation of oval cells. Also here colonic mucosa and proliferation of oval cells. Clinically, the case suspected to have rectal mass with suspicious colonic imaging, so multiple deeper sections were performed. And this is the deeper serials, slides of deeper serials. The first serial showing a single gland without goblet cells embedded in oval cells proliferation. Another this is a high power on 200 high power field gland without goblet cells. Deeper serials performed revealed multiple glands without goblet cells embedded through proliferation of oval cells. More high power gland without goblet cells embedded through oval cells. So it's clear now our diagnosis is endometriosis. And now it's time for immunostaining. We do cytokeratin 20, which stains positive for colonic gland and negative for
Sorry, Dr. Aya, unmute yourself.
Do you hear me, Dr. Mohammed?
Yes, doctor, I can hear you now.
Okay. CDX2 stains positive for colonic glands and negative for endometrial glands and oval cell proliferation. It's also CDX2 on 200 higher feet, also positive for colonic glands and negative for endometrial glands. Cytokeratin 7 stains negative for colonic glands and positive for endometrial glands. Also here cytokeratin 7. ER stains positive for oval cell proliferation. ER on more high power stains for both for oval cell proliferation and negative for colonic glands. ER also stains positive for oval cells proliferation with endometrial glands. Also ER stains positive for oval cells proliferation and endometrial glands. Now we will talk in brief about endometriosis, which is a benign disease of female genital system caused by implantation of endometrial glands with its stroma outside the uterus. We can call it as ectopic endometrial tissue. Its prevalence about 10 up to 1500 in women of reproductive age group. The main age of diagnosis is between 25 up to 29 years old. These two photos of classic histology of endometriosis. Endometrial gland with nuclear clearing and its stroma with fine capillary. Site of endometriosis ovary, anterior and posterior Douglas pouch, posterior broad ligament, uterosacral ligament, uterus, fallopian tubes, sigmoid pole, the appendix broad ligament, also seen in bladder and cervix, rarely in remote areas like lung, lymph nodes, and skin. Bowel endometriosis is gastrointestinal involvement known to occur in 30 up to 37% in cases of rectosigmoid being the most common site of involvement. It is considered a type of deeply infiltrating endometriosis. Is typically presented by involving the serosa and muscularis propria, rarely involvement of the submucosa and the mucosa. These two photos illustrate to us sites of bowel endometriosis, here in small intestine and the appendix, and here in large intestine. This blue color is deeply infiltrating endometriosis. This yellowish color is superficial peritoneal endometriosis. Red color is adenomyosis, which is embedded of endometrial gland through the myometrium. Bowel endometriosis, it's about 90% of bowel endometriosis involves rectum and sigmoid colon, while 10% of bowel endometriosis involves the appendix and ileum. Endometriosis increase the incidence of diaphragmatic endometriosis. About 15 up to 20% of bowel endometriosis is multifocal, while the rest is multicentric. Clinical presentation, the main key to diagnose or suspect bowel endometriosis is cyclic manner of alternative bowel habits, dyschezia, rectal bleeding, which promotes the clinician to consider endometriosis as a part of differential diagnosis. Also bowel obstruction and perforation, but these clinical conditions may mask colonic endometriosis with inflammatory bowel disease, irritable bowel syndromes, and malignancy or even appendicitis. The diagnosis of bowel endometriosis depends on good clinical history and the correlation of symptoms in appropriate clinical setting to suspect the diagnosis, aided by radiological assessment and endoscopy, but still histopathological examination is a confirmatory method. This photo is about endoscopic finding in which we saw narrowing, bulging into the lumen. Sometimes we saw polyp or mucosal change with erythema and granularity. CT abdomen is not diagnostic for endometriosis, but the imaging of choice is MRI in addition to pelvic ultrasound, as MRI can help us to detect the smaller sites of endometriosis, especially along the bowel and the pelvic ligaments. MRI can also detect the deeper structure affecting, which is difficult to detect by ultrasound. This picture of a sign is common in CT abdomen, which called the apple core lesion, when we suspect malignancy or endometriosis. Colonoscopy with biopsy is traditionally not considered a diagnostic tool for colorectal endometriosis. Diagnostic delay of endometriosis is still an area of concern. We recommend that deeper tissue sampling techniques, wherever possible, will help to achieve diagnosis less invasively. Also, endoscopic sampling may avoid surgical intervention by limiting extensive bowel surgeries and associated complications. We can end by saying that endoscopists to dig deeper for bowel endometriosis in the right setting. Our home message: number one, to respect the clinical impression and the provisional diagnosis. Number two, examination of multiple serial sections is advisable for proper evaluation. Number three, good clinical history and the correlation of symptoms in appropriate clinical setting are key in suspecting the diagnosis. And I would like in the end to thank you, Dr. Muhammad Kamel, and my dear Professor Dr. Shaya Al-Gohri, for this opportunity to share in this conference. Thank you.
Thank you so much, Dr. Aya, for such interesting case. I personally